Welcome to the Step 2 High Yield section on Pediatric Endocrinology. We're going to start with infants of diabetic mothers, move on to congenital adrenal hyperplasia and the 3 conditions most associated with it, and finish with vitamin D deficiencies and the effects seen in children. Let's start this section with the vignette. A 10.5-pound infant is born to a mother with type 1 diabetes. Upon examination of the newborn, he is shaking and has a holosystolic murmur that is heard over the precordium. The baby's right arm is adducted and internally rotated. His lab findings show an elevated bilirubin. The question is, which of the following is the most appropriate next step in management? Classic step 2 question. Insulin, blood sugar, serum calcium levels, serum TSH, CT head and neck. Now, I'm highlighting the fact that it's a 10.5-pound infant and that mom has type 1 diabetes. Always pull out what's most relevant in the vignette and always remember what you're being asked. What's the most appropriate next step? Not what's a step that's going to take place eventually, but what's the most immediate next step. The baby in the previous vignette is an infant of a diabetic mother. These infants are at increased risks of several problems, almost all of which are dependent on how well the mother's diabetes is controlled throughout the gestation. Now, the way this happens is maternal hyperglycemia, i.e. lack of control of maternal glucose, leads to a hyperglycemia in the fetus and the infant, i.e. all the sugar that's delivered to the fetus via the placenta ends up overstimulating the beta cells of the pancreas in the fetus. Now, the beta cells are responding appropriately to hyperglycemia, but the hyperglycemia eventually leads to hyperinsulinemia. And it's this fact that leads to many of the issues that don't really become a problem until birth, which we're going to cover now. There are 4 primary issues related to the hyperglycemia and hyperinsulinemia seen in the fetus and the infant. They present as macrosomia, hypoglycemia, electrolyte abnormalities, and jaundice. In discussing macrosomia and its relationship to infants of diabetic mothers, let's clarify the difference between macrosomia and large for gestational age, LGA, because they get thrown around a lot, not just large babies, but key differences in IDM. Macrosomia, by definition, is an infant that weighs more than 4,500 grams. It's about 9 pounds, 14 ounces. This is different than LGA, which is any baby that is among the top 90th percentile in weight and size. But the macrosomia that exists in IDM is different than simply a very large baby, and we're going to discuss how those differences play out. The 2 major facets that contribute to to macrosomia existing in infants of diabetic mothers is that these children are given an excess of amino acids and glucose and other building blocks that cause growth. They're then given an excess of insulin. So the hyperglycemia is a condition in which it actually gives an excess of building blocks that are needed for growth in the fetus. And then the hyperinsulinemia that's a consequence of the hyperglycemia leads to signaling to cause growth in the fetus. So you're not just telling the fetus to grow more, you're also giving it the tools to grow more. The major consequences of this are trauma and an increased risk of C-section. Now, recall from the high-yield pediatrics lectures earlier on the injuries to the newborn, macrosomia is a big risk factor for shoulder dystocia. Shoulder dystocia makes a baby at greater risk for things like clavicular fractures and injuries to the brachial plexus. The increased risk of a C-section makes the child more vulnerable to things like transient tachypnea of the newborn, because C-section means they're retaining more of the amniotic fluid in their lungs rather than it being squeezed out had they gone through a normal spontaneous vaginal delivery. Now, transient tachypnea of the newborn is a benign condition in and of itself, but undesirable nonetheless. There is no treatment for macrosomia. The only thing we can do is try and prevent it by controlling mother's glucose during gestation. Now, as we said, there's maternal hyperglycemia leads to infant hyperglycemia, leading to infant hyperinsulinemia. But the real problem is when the baby's born, because after birth, you no longer have infant hyperglycemia. You're only left with infant hyperinsulinemia, and that's in and of itself a major problem. Now, the hypoglycemia of the infant of the diabetic mother is a direct consequence of the maternal hyperglycemia, because as we showed, it's maternal hyperglycemia leads to infant hyperglycemia, leads to infant hyperinsulinemia. These hypertrophied pancreatic beta cells of the infant are overproducing insulin and creating a hyper-responsive insulin state. So not only do they have an excess amount of insulin in their system, wiping out their glucose, but when given a glucose challenge, they actually respond, they over-respond to it, further lowering glucose levels when presented with glucose. And so what happens is after birth, when you clamp the cord and the maternal hyperglycemia is no longer present, the infants don't have a liver that's used to releasing glucose. This is a baby that's been connected by a cord to mom for a long time, getting all its glucose that way. The liver of the infant isn't ready to release glucose as necessary when levels drop very low. So boom, they have this insulin that's just going to wipe out all their glucose stores and lead to dangerously low levels of glucose, severe hypoglycemia. And one of the dire consequences of that are seizures. Now, the treatment of this is key. This is where people get tripped up on the test. They see infant of a diabetic mother, for some reason they think diabetes, and they think the answer is insulin. Do not give insulin. Like we've said, they've got hyperinsulinemia, leading to hypoglycemia after they're born. So insulin is never the right answer. So we highlight glucose here because you need to give glucose to the infant of the diabetic mother. Mom needs insulin, child needs glucose. Now moving on to hypocalcemia of the infant of the diabetic mother. The causes are unclear, but a high yield thing to know is that it's intimately related with hypomagnesemia and hyperphosphatemia. And it presents in the infant with twitching and tremulousness because of the relationship that calcium has with muscles, and cardiac arrhythmias for the same purpose. Large calcium shifts can lead to cardiac arrhythmias and even can stop your heart. Now, the reason you need to know calcium and magnesium are linked is because if you see hypocalcemia or an abnormality in the magnesium level, you have to check the other one because they have to be corrected together. Or said more clearly, you can't correct a calcium abnormality until the magnesium is corrected, because a patient with both hypocalcemia and hypomagnesemia, if you try and give them calcium, they'll continue to dump it via their kidneys because of the magnesium abnormality. So always correct calcium with magnesium. You can't correct it by itself. And in the infant of the diabetic mother, these kids have twitching and tremulousness, and you have to be concerned for cardiac arrhythmias. Jaundice is very common in infants of diabetic mothers. A third of them will develop a hyperbilirubinemia. Now this tends to be a unconjugated indirect hyperbilirubinemia that occurs early in life but is not to be confused with transient hyperbilirubinemia. So this is not a direct hyperbilirubinemia that might be seen with an anatomical obstruction or infection of the hepatocytes. It's usually due to an overproduction of bilirubin. That's because infants of diabetic mothers have multiple reasons why there would be an overproduction of bilirubin due to an increased breakdown of red blood cells. They tend to have hematomas. Like we said, the macrosomic kid is going to have more prone to trauma during the birthing process. And so resolving hematomas mean for a temporary period of time an increased breakdown of red blood cells. That leads to increases in indirect bilirubin. Related to polycythemia. Polycythemia also is more common in infants of diabetic mothers. And so the polycythemic kid is going to have more red blood cells to break down, leading to an increase in indirect bilirubin. The treatment is the same as any other hyperbilirubinemia, and it's phototherapy. Conjugates, transforms the bilirubin, and allows for its elimination. Now returning to our vignette, the answer should pop out to us. You need to check a blood sugar level. Knowing that this infant was born to a diabetic mother, we should immediately check for hypoglycemia and check frequently, ready to provide glucose when it's necessary. Further, because we know this is an IDM, we know that A is wrong. These kids tend to be hyperinsulinemic, so the last thing they need is IV insulin. The majority of IDMs are going to have some hypoglycemia within the first 24 hours, so providing insulin would only make the ratio go up. Now, hypocalcemia is a concern and it's important, but it's less common than hypoglycemia. So between checking a blood sugar level or a calcium level, you're going to check blood sugar first. Now, this kid is shaking, but we don't know if it's shaking because it's cold, shaking because it's hypoglycemic, or shaking because it's hypocalcemic. But regardless, you got to check the blood sugar, and then you'll worry about sending off the blood for a calcium level. TSH is a screening tool for congenital hypothyroidism, and while it is a great congenital test, hypothyroidism is typically asymptomatic at birth. And the reasons it's screened for is the prolonged low thyroid hormone can lead to irreversible mental retardation, and therefore all babies are screened with TSH levels, even if they look healthy, but our infant's clearly symptomatic, and it's not going to be from a low TSH level. And then lastly, a CT head neck would only be if we had reasons to think that there was a bleed here or a trauma, but in an IDM, before you would send the kid out for a CT head neck, which can take 30 minutes or more, you're going to check a glucose level because you can correct hypoglycemia right away. Congenital abnormalities are not at all uncommon in IDMs, so one to know is that there's a fairly specific congenital abnormality in infants of diabetic mothers, and it's called small left colon syndrome, and it's diagnosed by barium study and treated with surgery. Respiratory distress syndrome is also a condition that's more common in infants of diabetic mothers because they're more likely to be macrosomic and too large for normal spontaneous vaginal delivery. So because they're more often born via C-section, they retain the amniotic fluid in their lungs, making them more prone to RDS. And then lastly, cardiac abnormalities like VSDs and ASDs are more common in infants of diabetic mothers. Recall in our vignette that we just went over, there was a holosystolic murmur. And there are only 3 types of holosystolic murmurs. It's either mitral regurg, tricuspid regurg, or VSD. Now, there probably aren't a lot of great reasons why this kid would have had tricuspid or mitral regurg. And considering VSD is the most common congenital heart abnormality in all children, then that's a great reason why you'd have a holosystolic murmur, particularly located over the precordium rather than at the apex, which is where you would hear mitral regurg. So VSD, very common. Now let's talk about congenital adrenal hyperplasia and the 3 main enzyme deficiencies that are easily tested topics on step 2. First, don't copy down the diagram I'm about to display. It's very complicated and a simpler version is going to appear later. But we'll use this first diagram as a reference for the main enzyme deficiencies that occur in steroidogenesis and how they ultimately play out clinically. Now recall from step 2 that cholesterol becomes a substrate called pregnenolone. This is the last substrate before major branching takes place to make the 3 main steroids for endocrine and hormonal purposes. The first is aldosterone, which is a major mineralocorticoid. The next one is a glucocorticoid, cortisol. And lastly, there are the sex hormones, testosterone and estradiol. Now, 17-alpha hydroxylase deficiency blocks at a particular place that leads to the absence or underproduction of cortisol and sex hormones. 21 hydroxylase deficiency leads to the underproduction of aldosterone and cortisol, but leaves sex hormones totally alone. The same is true of alpha beta hydroxylase deficiency, but it happens more distal in the process. Now, each of these leads to a very different clinical picture with some similarities and important differences that are key to you getting the question right on the test. All right, let's get started. Here's a simplified version of a diagram that's going to focus on the outcomes of each of these deficiencies and how they clinically present. When it comes to congenital adrenal hyperplasia and the presenting symptoms, we're concerned about the over and under production of 3 things: aldosterone, cortisol, and sex hormones. In 17-alpha hydroxylase deficiency, this ultimately leads to the blocked production or the underproduction of cortisol and the sex hormones. So you get too much aldosterone. And the reason that happens is without cortisol, you don't have cortisol feedback inhibiting ACTH release from the brain. ACTH is a potent signaling mechanism to produce more steroids from cholesterol. So you lose this cortisol, which is very little on your screen, so a lot of ACTH is going to be signaling the adrenals to make more and more steroids. But all this steroid production is going to basically get shunted over to aldosterone. So you have a hyperaldosteronism, and that leads to various consequences. First of all, aldosterone is going to lead to sodium retention and ultimately volume retention, causing hypertension. So you're going to be hypertensive kids. Also, aldosterone causes the dumping of potassium. In order to retain that salt and all that water, they dump potassium, so the kids have hypokalemia. The lack of sex hormones in these children is going to have differential effects depending on what their real chromosomal gender is. So in boys, they end up having a condition called pseudohermaphroditism. That is, they look like females externally, but they don't have female reproductive organs on the inside. So the reason is because it's an absence of virilization. It's a lack of virilization and signaling to turn them into boys on the outside, but they're still boys on the inside. Chromosomal females, on the other hand, XX, they're going to be phenotypically normal because the absence of virilization is fine for them. They don't want to be virilized. They look like females on the outside. They have female reproductive organs, but when it comes time for puberty, they don't have the sex hormones that lead to secondary sex characteristic development. So they don't have menarche, they don't develop breasts, they don't have pubic hair. Now here, we're going to start constructing a table that highlights everything you know about the three conditions so we can compare and contrast them easily. So in 17-alpha hydroxylase deficiency, running through it quickly, they have too much aldosterone because the enzyme deficiency leads to an underproduction of cortisol and an underproduction of sex hormones. They are hypertensive. The excess aldosterone leads to hypertension. Sexual development-wise, the girls are normal at birth and they don't really present till they're in puberty, but the boys are pseudohermaphroditic. Electrolyte abnormalities, they have hypokalemia. And a tip, the classic presentation of this is going to be teenage girl presents with delayed puberty and incidentally found to have an elevated blood pressure. All of a sudden you got to check her for a 17-alpha hydroxylase deficiency, which to this point has been underwhelming in her. This is very different than what we see in 21-hydroxylase deficiency, where the two pathways affected are the ones to aldosterone and cortisol, leaving an uninhibited path to production of sex hormones. This is overwhelmingly the most common inherited problem of steroid production, and therefore probably the one you should know better than all of them. First, with the loss of the production of the aldosterone pathway, you have a key difference between this and what happens in the 17-hydroxylase deficiency. Whereas in the 17-hydroxylase deficiency, the overproduction of aldosterone led to hypertension and hypokalemia because you retained salt and water and dumped potassium. The absence of aldosterone is obviously going to lead to the retention of potassium, and so you're going to have a contribution to hypotension and a retaining of potassium. So it's going to be hyperkalemic. Second, the absence of cortisol in conjunction with the absence of aldosterone, you're basically leaving two inherent pressors. So no cortisol also means you lose an ability to retain sodium and water from the kidney. So that's why these children often have low blood pressure, hypotensive. Further, this absence of cortisol is really what drives this to be such a debilitating disease, is because like in 17-alpha hydroxylase deficiency, no cortisol means there's nothing to inhibit ACTH release from the brain. So now that ACTH is traveling to the adrenal glands and is constantly signaling it to make more steroids, but it can't make aldosterone or cortisol, so it ends up making a ton of sex hormones. And this is what leads to the major changes in the sex characteristics of children, which is the exact opposite of what happens in 17-alpha hydroxylase deficiency. The males look phenotypically normal. There's no phenotypic effect. They need the testosterone, they end up getting the testosterone, which allows them to virilize appropriately. But in females now, they have inappropriate virilization. Your XX genotypic females end up looking phenotypically like a female with male external reproductive organs. So they maintain the uterus and ovaries internally, but develop into males externally, and this can lead to some major issues. So it's the underproduction of aldosterone and cortisol and the overproduction of sex hormones, which are the prominent effects of 21-hydroxylase deficiency. Now, putting what we said into a table format will allow us to easily compare this to 17-alpha-hydroxylase deficiency. Now, there's underproduction of aldosterone. That's the first part that's different. But there's also the underproduction of cortisol. Those two things together play a critical part in how these patients present, and namely it's because they don't have the ability to retain salt, so they lose all their salt, they lose all their fluid, and they develop hypotensive salt-wasting shock. The increase in sex hormones, which is driven by the ACTH increases because there's no cortisol, leads to the differences in sexual development. So as we said, these patients are hypotensive. They have salt-wasting shock, and that's because they have no aldosterone and no cortisol. The differences in sexual development is that now it's the girls have the issues. They are virilized at birth, developing male genitalia externally, but retaining female reproductive organs internally. The boys are normal at birth because the excess sex hormones don't affect them. They actually need the sex hormones, particularly testosterone, for the development of male genitalia. And the electrolyte disturbances are directly related to the absence of aldosterone and cortisol. They waste salt, so they're hyponatremic as well as hypochloremic, and specifically because of the lack of aldosterone, they end up hyperkalemic. The last of the three enzyme deficiencies we're going to discuss is 11-beta-hydroxylase deficiency. It works along the exact same pathways as 21-hydroxylase deficiency, but it happens more distal, and this has critical consequences that make it a very different syndrome. Now, just like 21-hydroxylase deficiency, there is a loss of aldosterone and cortisol production, leading to an overproduction of sex hormones. And the same thing that occurs in the other syndromes is that without the cortisol, you have a loss of feedback inhibition of ACTH, and you have constant ACTH stimulation of the adrenal glands, leading to increased constant steroid production. Now, so whatever's being produced is being overproduced, and that's a critical aspect of what makes this syndrome very different from 21-hydroxylase deficiency, because the fact that the deficiency is occurring further along the mineralocorticoid pathway means that there is one mineralocorticoid that still gets produced, and it's called 11-deoxycorticosterone, 11-DOC. This isn't as potent as aldosterone, but it still works. So this syndrome kind of looks like an overproduction of aldosterone with an overproduction of sex hormones and an isolated reduction in cortisol. So we see a shunting of steroidogenesis towards the sex hormones, which will cause virilization like we saw in 21-hydroxylase deficiency, but we see this 11-DOC produce some mild mineralocorticoid effects. So here we're going to complete our table so we can compare across the board between our three deficiencies. Now on the surface, 11-beta-hydroxylase deficiency looks a lot like 21-hydroxylase. Low aldosterone, low cortisol, and increased sex hormones. But the critical difference being the increase in the 11-DOC, which makes these kids hypertensive. So the key difference being in that is that because all three of these deficiencies lead to the loss of cortisol, that leads to constant ACTH stimulation of the adrenal glands to make whatever steroids are available. And in the case of 11-beta-hydroxylase, that leads to not just the production of 11-DOC, but the overproduction of 11-DOC. And because it's a weak mineralocorticoid, it's going to lead to hypertension as opposed to the hypotension and salt-wasting shock syndrome of 21-hydroxylase deficiency. But similar to the middle column, 11-beta-hydroxylase is going to have similar sexual development because they both have increase in sex hormones. So the girls are virilized and the boys look normal at birth. But unlike the other two columns, 11-beta-hydroxylase has very few electrolyte abnormalities. And that's because the 11-DOC, there's enough of it there to keep them from becoming hyperkalemic, but there's not enough of it to keep them from going hypokalemic. So they're not going to dump too much potassium, and they're not going to retain too much because it's a weak mineralocorticoid. And here's another final look at the more complicated steroidogenesis diagram that isn't really necessary to know, but it's just to sort of show where in the whole process these deficiencies occur, and that the only difference between 11 beta hydroxylase and 21 hydroxylase deficiency is that there's just one substrate difference between them. But that small difference is enough to make very different clinical presentations. Rickets is a disorder of children. Specifically, it's when children develop soft and weak bones that leads to an increased incidence of fractures. As simple as that. Vitamin D, calcium, and phosphate working conjugation with each other in a large, complicated metabolic pathway involving many organs to maintain bone health. And when any one of them is out of whack, the whole system gets thrown off and children end up with an increased incidence of fractures. Children are particularly susceptible because, first of all, their bones are growing rapidly. And when you're trying to incorporate a great deal of calcium and phosphate into a matrix and it's not there, then the bones either don't grow or they grow and they're just weak. And particularly younger children, those who are still breastfeeding, are also susceptible because breast milk lacks vitamin D to begin with. That's why youngest of children are given prophylaxis with vitamin D supplements. This diagram is intended to convey the complexity of bone metabolism and reveal that little problems in one place can lead to big problems all over the body. I think there's a way of simplifying the previous diagram to drive the point home. Now, recognizing that there are many feedback loops that come into play, let's focus on just the main players to understand how bone metabolism relates to bone health and can bring about things like rickets and fractures in children. You start off with two primary hormones, vitamin D and parathyroid hormone, PTH. They act on three main players, the GI tract, the bone, and the kidneys, all ultimately to control the balance of two electrolytes, calcium and phosphate. Now, in response to a low calcium, parathyroid hormone is going to act on the kidneys to increase calcium absorption in the distal tubule and decrease phosphate absorption in the proximal tubule. Further, PTH acts on the bone. It's going to lead to resorption of bone, which is activating osteoclasts to release calcium and phosphate, because calcium and phosphate join together in a matrix to make bone. So the osteoclast, when it breaks down bone, both of them go into the bloodstream, increasing their serum concentrations. Next, PTH leads to the vitamin D secretion. Now, vitamin D, whether it's ingested or made, released endogenously via the PTH route, is going to act on the GI tract, and that's going to lead to the increased absorption of both calcium and phosphate from your diet. It's also going to act on bone to lead to resorption as well, and as we already said, that leads to increased serum calcium and phosphate levels. The net effect is to increase the levels of calcium, and eventually this will lead to a feedback mechanism that stops this whole process when calcium levels normalize. Without vitamin D, you have the loss of its effects on the GI tract and the bone. If vitamin D is responsible for promoting bone resorption, which releases both calcium and phosphate into the system, and vitamin D is responsible for GI absorption of calcium and phosphate, then without vitamin D, you have a drop in calcium. This drop in calcium triggers the release of parathyroid hormone. It's going to try and maintain calcium levels by increasing bone resorption, acting on the kidneys, and promoting vitamin D release. Now, because in normal homeostasis, PTH exerts some of its homeostasis effects via vitamin D, there is no vitamin D. So you have continual loss of calcium and phosphate due to this continued vitamin D deficiency. The levels eventually can't be maintained, and calcium continues to drop off, leading to greater PTH release and more bone resorption. This eventually whittles the bone away. And for this reason, you also have continued phosphate losses. And that's why in patients who are suspected to have vitamin D deficiencies, the classic lab abnormalities you'll see is a low calcium, a low phosphate, an elevated alk-phos from the increased bone turnover, and elevated high PTH levels. And this is all from the lack of feedback inhibition from vitamin D. This process continues until you get a child with an x-ray like this. The bowing of the femur and the tibia from walking on very soft bones bends them inward. And for the treatment, you just got to give them vitamin D and calcium supplements. Giving them vitamin D alone is going to help. You want to give them high doses of vitamin D and high doses of calcium to try and rebuild the matrix of their bones. So that ends our Step 2 High Yield Pediatric Lecture on endocrinology, where we covered the infants of diabetic mothers, the 3 enzyme deficiencies of congenital adrenal hyperplasia, and the effects of vitamin D deficiencies in children, and how the physiology plays into it.